Stanford University.
Okay, good evening. Thank you so much for coming. And I meant for this to be an overview. We could, I'll be happy to answer anybody's questions afterwards if this is not detailed enough. So basically, I thought the objectives of this talk would be, one, to define what celiac disease is, also understand some of the epidemiology, as well as understand some of the basic pathophysiology. And we'll discuss about how the diagnosis is made and discuss treatment. So what is celiac disease? Well, celiac disease is basically a permanent intolerance to gluten. Gluten is a storage protein that's found in wheat, barley, and rye. It's made up of some families of proteins called glutenins and gliadins. In the case of celiac disease, gliadins are the toxic component. And basically, repeated gluten exposure causes chronic inflammation in the small intestines, and this is basically drives an immune response that, in a sense, attacks the intestine. So it's attacking our own body, and it's considered an autoimmune disease. Celiac disease is also known as celiac sprue or gluten-sensitive enteropathy, also non-tropical sprue. So how common is celiac disease? It's about 1 in 100, it affects about 1 in 133 people in the United States. And this translates to about 2 million people. And among people with affected first-degree relatives, meaning someone who has a parent, a child, or a sibling, the risk of having celiac disease is actually 1 in 22. So it's very common. It's also associated with other autoimmune diseases, including type 1 diabetes, autoimmune thyroid disease, autoimmune liver disease, Addison's, Sjogren's syndrome, Down syndrome, and Turner syndrome. So before we get into how the celiac disease causes injury, I thought we'd discuss what the small intestine normally does. And basically, this is a cartoon that I borrowed from the internet. And what it shows is basically the gastrointestinal tract. And the small intestine is kind of jumbled up here in the middle. So the small intestine, which is basically what you see all jumbled up in the middle, is about 20 to 25 feet long. And it's lined with very tiny finger-like projections that we call villi. And so this is a small intestine. It's very long. And this is the lining of the small intestine. So pretend it's been cut open. And the lining is basically very tiny finger-like projections that are called villi. And after we ingest food and it gets chewed to small particles, this is where it gets absorbed. And this cartoon is just a more detailed version of what's going on. What you see here, this hollow tube represents the small intestine. Inside you see the lining with all the tiny villi. And this unit is very important. It has blood supply and also drainage and what it basically does is when the nutrients arrive at the small intestine all broken down and need to be absorbed, this is where they get absorbed. And the problem in celiac disease is that this unit is injured because that's where the inflammation is going on. So as a result, you're not absorbing some really important nutrients. And this, in a sense, is the problem. When a person with celiac disease ingests or uses any products containing gluten, his or her immune system reacts by attacking and injuring the small intestine. So in talking about what causes celiac disease, well, there's not only one cause, and it seems to be an interplay between genetics. So you have to have the right genetic makeup. Also, there's defects in immunity, and also environment plays a role. By environment, I basically mean gluten in this case. In terms of genetics, there's been 2 genes that are associated with celiac disease that we're going to talk a little bit more about. When I talk about immunity, I mean the body's defenses against pathogens. And it's broken down into innate immunity and adaptive immunity. Innate immunity is the evolutionary conserved, hardwired defense against pathogens that's nonspecific. So we're talking about the barriers, like the skin barrier and barriers that protect us from bacteria that could take over our bodies. Adaptive immunity, which is more along the lines of much more specific. So this involves inflammatory cells and including T cells, which we will talk a little bit more about as well. And these cells are specialized to protect us against pathogens, either bacteria or viruses. And in celiac disease, it appears that the immune system is affected and also it plays a role. So not only is there a problem with the immunity, you have to have the right genetic makeup, and in this context, gluten will trigger inflammation. So what is this cartoon? This is a cartoon that I borrowed from a review article in the New England Journal of Medicine. And it's basically a very detailed version of what's going on in the villi at a molecular level. Here you have the lumen of the intestine, so that's where the nutrients are coming from. And these cells represent basically the barrier that exists between the lumen and the rest of the small intestine, where it meets the blood flow and everything else. And what happens in celiac disease is that there's increased permeability, so now this barrier is not as efficient as it is in normal people. So the gluten peptides, and remember, gliadin is the one that is the toxic component here, can go through this cell barrier and interact with the inflammatory cells that are called T cells. Now, in order for the T cells to be able to recognize gliadin, they have to have expression of the genes that I talked about, DQ2 and DQ8. And this is what you see here. And to make gliadin even more toxic, there is an enzyme in the small intestine that converts gliadin from just run-of-the-mill gliadin to a more active form, which is much more attractive to the T cells. So once the T cells or the inflammatory cells recognize this toxic gliadin, what happens is that chemicals known as cytokines are released, and this culminates in inflammation. And this inflammation causes injury to the cells and leads to what we call villus atrophy. And when the villi are injured, nutrients are not absorbed as well. So let's talk about the genetics. So I talked about these 2 genes, DQ2 and DQ8, which are expressed in the inflammatory cells, and they're required for this gliadin toxic peptide to be recognized. So it turns out that over 95 to 97% of celiac disease cases have one of these two genes, either DQ2 or DQ8. And these cells, just to reiterate, they're present in the inflammatory cells. And it's through these genes that gliadin is recognized, or the gluten peptide gliadin is recognized as a pathogen. DQ2 is the more common one. It's found in 90% of celiac disease patients. DQ8 occurs in about 5% of the cases. Of interest is that over 20 to 30% of normal healthy people have DQ2, and about 10% of normal individuals have DQ8, yet they don't have celiac disease. So even though they seem to be a requirement for developing the disease, having the genes doesn't necessarily mean that you will have celiac disease, but it does. Having these genes will increase your risk of developing celiac disease. It also illustrates that it's an interplay between the environment and also these other factors that we talked about. So what does celiac disease look like to us when we're looking endoscopically? On the left is a normal picture of a small intestine, and on the right is somebody with celiac disease. And what I'd like to draw your attention to is that here it's a very uniform carpet-like lining, so that the villi are very well preserved, and basically with ongoing inflammation, what happens is that there is scarring, there's what we call scalloping, and the villi lose their integrity. And we also see a lot of what we call mosaic patterns. So it could be very patchy. Like one part of the small intestine could look almost normal, whereas the other part could look completely denuded. And there's also, in severe cases, you could see ulcerations. So what are the consequences of celiac disease? So we talked about how important the small intestine is to absorbing nutrients. And basically, one of the consequences of active disease is malnutrition. And there's also malabsorption. And the key nutrients that are lost here are calcium, iron, vitamin D, the fat-soluble vitamins, which includes vitamin D, also electrolytes and water. And this could lead to anemia and osteoporosis. Also, it could lead to liver disease, and in some cases also cancer of the small intestines. So what are some of the common symptoms of celiac disease? Well, since the small intestine is highly affected usually, it makes sense to think that it would have a lot of gastrointestinal symptoms. And some of the symptoms that we see that are most commonly see are abdominal pain and bloating, chronic diarrhea, vomiting. We could even see constipation, which it is a little atypical but could be seen. But also pale, foul smelling or fatty stools, and weight loss. Interestingly, however, there's a lot of other symptoms that have nothing to do with the GI tract or that are not gastrointestinal symptoms. And one of the most common things is iron deficiency anemia, fatigue. People often complain about bone pain and arthritis. Also, neural symptoms like neuropathy, numbness in the hands and feet, seizures, and also some rashes. For celiac disease is specifically something called dermatitis herpetiformis that we'll talk about a little bit more later. But this is not surprising either, because the intestine is the point where a lot of, like I said, the nutrients, very essential nutrients, are absorbed, and these nutrients are required for many processes around in the human body. So it makes sense that we would see such global symptoms. And the pie chart here just is one investigator's study, basically looking at how frequent the different symptoms manifests. So because celiac disease affects so many aspects of the human body, during the NIH Consensus Development Conference in 2004, they came up with some classifications that I wanted to share with you. Classical celiac disease is a celiac disease that we've known about for many years, which the symptoms that we see are attributed to the gastrointestinal injury and malabsorption. Atypical celiac disease, basically, we see a lot of extraintestinal manifestations. So not much by way of gastrointestinal diseases, but we see a lot of other symptoms like what I showed you in the second slide. Silent celiac disease refers to individuals who are asymptomatic, but they have positive blood tests. And when we look at the biopsy, at the actual small intestine and take biopsies, we see villus atrophy. Latent celiac disease is defined by having positive blood tests, and also the small intestine is normal, but the small intestine is normal on biopsy. And finally, refractory celiac disease is people who have true celiac disease, but they don't respond to a gluten-free diet. We're going to talk more about treatment shortly. Or they stop responding to a gluten-free diet. And how is the disease diagnosed? So we have some very good blood tests available now. And these include anti-tissue transglutaminase. So this is antibodies against this molecule called TTG. If you remember when I talked about the pathophysiology, the enzyme that makes the gliadin more attractive to the T cells is TTG. So there's antibodies that are made to this enzyme, which we could detect on the blood tests. We also have antibodies called anti-indemesium, and also for deaminated gliadin peptide. So when TTG acts on gliadin, it makes a form that's called deaminated, and this is what we detect. And these blood tests are very good in the sense that they have good sensitivity, which means that they're good at picking up the disease. They also have very good specificity, meaning that if they're negative, the likelihood of having celiac disease is low. Intestinal biopsy is still the gold standard. And we do still see some false negatives on the blood tests. And what we look for in the small intestine is like the picture that I showed you. We're looking for nodularity, we're looking for scalloping or notching of the small intestine, mucosa, and we're also looking for mosaic patterns. Celiac disease could be a little tricky to diagnose in that it could be very patchy. Most of what's affected is the proximal small intestine or the very first part of the small intestine. But you could have areas that look normal alongside areas that are highly affected. Microscopically, when we're looking, what we look for is erosion of the villi or something called villus atrophy, and also migration of some inflammatory cells called intraepithelial lymphocytes. Finally, dermatitis herpetiformis is an intensely itchy, blistering rash that affects about 15% of people with celiac disease. Interestingly, a lot of the people who have this do not have intestinal symptoms. The rash usually occurs in the elbows, knees, and buttocks. If antibodies and biopsies of the rash are positive for dermatitis herpetiformis, then an intestinal biopsy is not required to make the diagnosis. nowadays, we also pick up celiac disease and screening of first-degree relatives of people who have celiac disease. And also, when we have like certain symptoms like unexplained iron deficiency anemia, fat malabsorption, we are very keen on looking for celiac disease. I put this slide in here because I wanted to remind myself to tell you that whenever we have to evaluate for celiac disease, basically it must be done while the patient's taking gluten. And the reason for that is basically I see a lot of patients in clinic who have read that gluten products could cause bloating, abdominal pain, so they self-medicate by omitting gluten, and then are interested in knowing whether they have celiac disease. Well, the way that celiac disease is treated is by omitting gluten. And basically, once gluten is out of the diet, in most cases, the mucosa begins to heal. So we could easily have false negative blood tests, and also the mucosa could look very normal in someone who's not consuming any gluten at all, despite having gluten, if that makes sense. So basically, once somebody's diagnosed with celiac disease, in terms of management, we are interested in looking for a variety of different processes because many things could be affected. And on a first visit after a diagnosis, we're likely to check a complete blood count, look at iron levels, look at liver function tests, vitamin D and calcium levels, as well as thyroid function tests. And generally, we follow bone mineral density because osteoporosis, because of the malabsorption of the vitamin D. Osteoporosis is very common, and we also monitor it after starting gluten-free diet. And our recommendation is basically anyone with celiac disease should be on calcium and vitamin D, and also should receive the regular vaccinations that are required, that are recommended, like the pneumococcal vaccine and the yearly flu shot. In treatment, basically, gluten exclusion or a gluten-free diet is the only effective treatment that we have available. And this requires a permanent lifestyle change. And in terms of the gluten-free diet, there's some obvious sources of gluten, and there's some hidden sources. And basically, here is products that we know have gluten. These are wheat-based products, so beer, crackers, bread, pasta. However, there's a lot of sources that you wouldn't think would have gluten, but actually do contain, like soy sauce. A lot of soy sauces do contain gluten. Also some malt from barley, vinegars, some flavorings in cereals, medications. And sometimes there's a medication that's been safe for a patient for years, then the manufacturers changed or the lot number changes, and all of a sudden it's a problem. That's because sometimes the binders that are used for medications could contain gluten, and there have been instances where the companies just change what they use to bind the active ingredients together. So we ask our patients, basically ask the pharmacist, check the packet insert if there's concern. But there's also some hygiene and other products that could be ingested that may contain gluten, like toothpaste, lip products, shampoo, and even glue on the envelopes. And some foods that do not innately have gluten, like French fries, could get mixed in with gluten, I guess, if it's prepared in the same container where gluten products are cooked. And processed foods are also a place that there's usually a lot of gluten. And I was surprised to find that also Play-Doh. So basically, wheat-free doesn't necessarily mean gluten-free, and it's you always have to be vigilant. So what can you eat? So these are some of the grains that are safe. And basically, you still have to be careful to make sure that the source where these come from are reliable, and that these are not mixed in with any gluten-containing products. So, as you could imagine, it's very difficult to adhere to a gluten-free diet, and this has been the subject of many research studies. And this study done by Dr. Leffler and colleagues basically followed a cohort of patients and kept very detailed diaries. And they found that among the factors affecting adherence to the diet include the presence of other food intolerances, concern over costs, subjective and objective perceptions of the gluten-free diet, the ability to follow the diet outside of the home, and also the ability to adhere to the diet irrespective of mood and stress. And in terms of monitoring adherence, this is a very difficult problem because we don't have a standardized way of monitoring adherence. And at the moment, nutritionist evaluation is the gold standard. And unfortunately, there is not, many of the nutritionists available are not celiac specialists. So the evaluation should be done by someone who specializes in celiac disease. Also, what the studies have shown is that serologic tests, or those blood tests that we talked about making the diagnosis, are not always reliable. In some cases, those antibodies come down with the treatment, but not necessarily. So they haven't proven to be a reliable way of following whether someone is taking in gluten or not. Some experts advocate repeating endoscopies, but this is a costly approach, and also each time that the person has an endoscopy, there's a risk of a complication. And in terms of when someone goes on a gluten-free diet and they haven't responded, so this is what also, again, Dr. Leffler and colleagues looked at, is like these are the main reasons why the patient isn't getting better. The biggest one is that somehow they're still the patients are still consuming gluten. And people could be very, very careful, but it's sometimes very hard to figure out exactly what the source of the hidden gluten is. And that's when a very experienced nutritionist would be very helpful. If this is adequately excluded, then there's other diseases that could coexist with celiac disease that need to be explored and treated. And here, I found this list of basically tips to avoid cross-contamination with gluten at home. And basically, the bottom line is like keeping the gluten-free products clearly marked and separate from products containing gluten. So we suggest designating shelves in a cupboard or refrigerator to make sure that you do that. And also avoid sharing items like peanut butter, butter, mayonnaise, so as not to cross-contaminate your products. And also avoiding using like the same toaster. Keep separate gluten-free baking utensils. avoid handling flour and things like this, and also just replacing some of the old pots and spoons often. And finally, I just wanted to leave you with the objectives, and these are the treatment objectives that were brought up by the NIH consensus meeting in 2004. One, it's really important to have, in order, if problems arise with treatment of celiac disease, consultation with a skilled dietitian, education about the disease, lifelong adherence to the gluten-free diet, identification of treatments of nutritional deficiencies, access to advocacy groups, and continuous long-term follow-up by a multidisciplinary team. And these are some of the organizations whose websites I find helpful. And with that, I will take questions. Sure. So the first question is how much gluten it takes to cause problems. And the second question was, so the gentleman has a grandson with celiac disease, so he's wondering if he will outgrow it. Is that accurate? All righty. So the first question, in terms of how much gluten, it doesn't take a lot. And actually, there's been studies which showing that even inhaling small amounts of flour could trigger the disease. In terms of growing out of the disease, this doesn't happen. It's actually, as far as I know, there's no reports of people without being treated with a gluten-free diet, just on their own, recovering from it. Okay, so you've had the disease now it was diagnosed 2 years ago, but presumably you had it before. And you're wondering what your chances are at being able to treat the disease. Well, unfortunately, right now, the only treatment that we have is adherence to this gluten-free diet. In most cases, respond to that. There is a small minority of cases, like that slide where I showed you, when people don't respond to the gluten-free diet, where we need to troubleshoot and try to figure out whether it's because somehow there's gluten getting into your diet, or if there's something else on top of that, like irritable bowel syndrome, or there's lactose intolerant on top of that. So I think what needs to happen is like have you met with a dietitian? Okay, great. And monitoring your blood tests, making sure that you don't have anemia. There are ways that we could track whether you are responding to the diet. And if things aren't healing, then they're going to require more further evaluation. Sorry. So in terms of the hereditary aspect, so there's clearly a link between people who have first-degree relatives with celiac disease are more likely to have it themselves. Whether it comes from the paternal or maternal line, to my knowledge, I don't think there's been a distinction between the two. I think it's equal on both sides. And it is a little bit more common in females, but it's a very small percentage. Yes? Yeah. So gluten or wheat seems to cause a lot of abdominal distress that's not celiac disease. And the verdict is sort of out as to exactly what is causing this. This is an intense area of research. And what we call this is gluten intolerance. Basically, it's thought to be partly that perhaps we have allergies to gluten or other wheat peptides. But the bottom line is like a lot of things get better on a gluten-free diet that aren't necessarily celiac disease. Celiac disease is this actual autoimmune genetic disorder And it's defined by having, the genetics, and also the blood tests are positive. And also we see the injury in the small intestine. With gluten intolerance, even though a gluten-free diet may make somebody feel better, the blood tests won't be positive. There won't be any injury to the small intestine. So it's a different mechanism, and it's poorly understood. Yes, sir? The mechanism for the extraintestinal manifestation is poorly understood. It's thought to be maybe some autoantibodies that are generated that somehow are attacking the body. But the mainstay still is the gluten-free diet. I think in order to treat the other side effects, we just use whatever armamentarium we have, like painkillers, and there haven't really been any anti-inflammatory medications that have worked for this. So there's not really, I don't have a really good answer for that. I've had some patients report that, but it seems to be many different symptoms across the board. Like a lot of people experience different sensations when some people could tell you, yeah, I know exactly when I take a bite out of something with gluten. Other people, nothing really happens that will alarm them. How soon do they become negative is very variable. In some people, this happens within weeks. Other people, it takes years, which is one of the reasons why we can't really use these serologic tests to follow adherence. When someone's been on a strict gluten-free diet and they're serologically negative, and we're in cases where we really are trying to make a diagnosis, we often do a gluten challenge, which means reintroducing gluten, which could cause a lot of distress to someone who has celiac disease, because that would mean that symptoms are coming back. And what a good rule of thumb would be 6 weeks before doing the full evaluation to try to make sure that we could every day, and having a minimum of 4 grams every single day. What makes gas in the intestine? Unfortunately, a lot of things, but partly of what we eat. So a lot of basically in the intestines, we have a lot of bacteria that help us break down nutrients, and this is a symbiotic relationship, basically. But if we consume things that are not well digested, that could produce gas. And in terms of gas in celiac disease, that's a completely variable symptom too. Some people don't report that as a symptom, while other people report bloating as a huge component of it. Yes, irritable bowel syndrome is a completely different entity from celiac disease, but sometimes the symptoms overlap. So irritable bowel syndrome is basically a disease of exclusion. Like we will say that you have irritable bowel syndrome, well, we've ruled out all the other things. Because the bottom line is there's a lot of research going on in that area, but we don't really fully understand exactly what's causing all of the symptoms. And it's an area of very intense research, and I think in the next 10 years or so, we're going to have a good handle on it. But with celiac disease, we basically have these set serologic tests. And, if somebody comes to us with abdominal pain, bloating, diarrhea, we're obviously going to look at the blood tests and see if there's anemia, see if there's osteoporosis, and make the diagnosis according to the blood test and the history as well. But a lot of times, irritable bowel syndrome is considered in somebody that has celiac disease. Yes, sir? Sorry. If the child is on a gluten-free diet and the disease is in remission, they should have normal growth and development. She's asking whether calcium and vitamin D should be supplemented in a person with celiac disease.
Thank you very much.
Thank you.
For more, please visit us at stanford.edu.